Hello, my name is Pat Jeffery. I'm one of the nurses at the STARS base in Calgary. And the purpose of this video is I want to show the EZ-IO Intraosseous. And hopefully it'll be a good refresher for everyone. What I'm going to do is cover 5 areas. I'm going to cover how an intraosseous actually works. I'm going to cover the landmarking. I'm going to go over the equipment. I'm going to go over how you give your lidocaine administration, and then I'm going to end with some tips and tricks that hopefully maybe will benefit some of you. I think what I'm going to do is just show you the tibia here first. The interosseous, you'll notice that our sites are all in the ends of long bones, okay? So it's the proximal humerus and then the proximal and distal tibia. And the reason we go after the ends of the long bones is because that's the epiphysis, okay? That is where you've got your bone marrow. This is where your red blood cells are manufactured. All of your platelets and 60 to 70% of your white cells are also formed in this area. So it's a fine network of blood vessels. So any medication or fluid put into that space will quickly be into the central circulation. And I have a really good diagram for this. Shows the proximal tibia in this case. You can see that the top of the tibia is actually quite a large triangular shaped bone, so you've got a big target to go after. And you can see you've got your blood vessels in there, and this is where your marrow is, and it's soft bone in there as well. And so any med or drug into this space will quickly be right into your circulation. Now, you'll notice the bone is actually quite thin, and it's thinnest at the ends of the bones, okay? So your cortex or the hard surface, and that's another reason why we like to go into the ends of the long bone. You'll notice as you come down the channel into the bone, it becomes, the actual channel or the cavity becomes thinner, and the bone becomes thicker, and you can see in this case how small a target you have. So if you're going to be doing a tibia site, you want to be up high, because the further down you go down on the tibia, you run into a greater chance of actually going completely through it into the back. I like to think of an EZ-IO as a bridge to a central line, and it literally is kind of a poor man's central line. You're going into a space that doesn't collapse, okay? This will never collapse on your patient. And so if you've got someone who's in shock, they're in cardiac arrest, things like that, this is the site that you want to go to, because any drug you give will be very quickly into your central circulation. I think people are very familiar with using an intraosseous, say in a cardiac arrest or a peri-arrest, things like that. But I think it's probably underutilized in patients that have higher GCS. When I worked in a nursing station in northern Alberta, I actually came on shift and the mother was screaming and she was laying on top of her toddler. And the nurses had tried 8 times to get an IV line on this child who was really severely dehydrated. And the mother was traumatized by it, not to mention the child. And she wouldn't let the nurses touch the child, and that's how it went. It was medevaced out. So that didn't need to happen. I think you can just quickly look at your child. Okay, this child's very dehydrated. There's no obvious IV access. Just do a quick tibial line on this child. You would have been able to give fluid and some glucose, and it would have had a much better ending. The other thing is anytime you traumatize someone with a lot of IV starts, this can follow them into adulthood, and then they really don't like needles and they don't like going to hospitals and things like that. The other thing is, I used this on a conscious trauma patient. She was polytrauma. There was one fatality on scene. She had fractured arms, legs, ribs, everything. The only bone that she didn't have fracture was her left tibia. And they had tried to get AC access on her. They were unable to do so. It was cold, it was in the wintertime, and she was in a tremendous amount of pain. And this, I'm thinking, holy cow, this will be the first time I'm going to do one on a totally conscious patient. And so I got her name. I said, Linda, what I'm going to do is I'm going to start this into your lower leg. And she said, whatever. She was in so much pain. And so I inserted it, and I said, what did that feel like? And she said it didn't hurt any more than when they were trying to get the AC ones. And I said, oh, good to know. So then I flushed my tubing, and I said, Linda, I'm going to put some freezing into this bone, and it's going to sting a little bit, but then it won't hurt anymore after that. And so I went to give the lido very slowly, and she went, ow, ow, and then she stopped talking. And I actually physically turned around to see if she'd gone unconscious on me, and she hadn't. She was still wide awake. And I said, Linda, how's that feel now? And she said, it stung when you first put the medication in, and it doesn't hurt anymore. So I slowly gave her the lidocaine over the 2 minutes. I let it sit for a minute to kind of marinate in the bone. And then I flushed it, and she said she could feel a little bit of the flush, but it was like half a 1 out of 10. And then what I gave her, I kind of paused in the lidocaine administration, and I gave her 100 of fentanyl. Because at that point, the only thing that didn't hurt was her left leg. Everything else, she was in a tremendous amount of pain. So once we got her global pain under control and gave her some TXA, then I was able to complete the lidocaine administration. Other times you can give it, certainly with seizures, I always kind of go with altered LOC, so seizures, ingestions, head injuries. If you've got an electrolyte imbalance where you've got low sodium, low glucose, high potassium is also a good case for that. Also in burn patients, it's very difficult to secure any kind of an IV to a burn patient, whereas with an IO, you can actually have it more secure into the bone, and then you can secure it in some fashion there. So yeah, so like I said, I think it's vastly underutilized in patients that are conscious, and I think the way of thinking is you think you're going to hurt your patient, when in fact, you're probably going to traumatize your patient more by trying to get a line. So we're going to go over landmarking, and the first thing we're going to do is probably the site that most people are familiar with, and that is your proximal tibia. Okay. Now this is a very good demonstration of it. Okay. You'll notice it's quite high up. I think most people don't realize that. The thing is, you want to go find your tibial tuberosity, okay, and then you want to go just medial to it, maybe 1 or 2 centimeters. And anytime you're using the legs, you're always going to be on the medial side of your legs, so the inside. So I always say easy IO, big toe. It's on that side of your body, all right? So if you can't find the tibial tuberosity, and I know a lot of people have issues with that, find the patella tendon. And again, in this photo, you can actually see the patella tendon quite well. All right? So if you can find that, the patella tendon actually anchors to your tibial tuberosity, right? So just bring it down and then again go 2 centimeters medial and you'll be in the right spot. Now, if you can't even get to the patella tendon, just find your patella and then you can go 3 centimeters below that and again go just 2 centimeters medial and you're in the right spot. Now for a child, it's a lot easier. If you can find the tibial tuberosity, just go 1 centimeter medial. And again, if you can only find the patella, just go probably 2 down from the patella and again 1 medial. In children, you actually have an additional site, and that is the distal femur. Now, it's a good site. It's a nice big bone. The only thing is you're going to have to keep that leg splinted straight, because once we put this in here, if you allow the child to bend the knee and bring it up, the quadricep muscles will pop the needle out, okay? So you're going to have to remember to keep the leg straight. The landmarking is very simple. It's 1 centimeter above the patella, and again, it's 1 to 2 medial. But again, it's a nice big target. It's a nice big long bone. So we're going into the epiphysis of those bones. All right. Now, for adults going down to the distal tibia, I think most people say, when on earth would we ever put one down there? Well, I kind of have a few pictures. These are just kids. All right? So kids come in all kinds of shapes and sizes, and so do adults. And if you have a large patient, maybe 200, 300, 400 pounds, and you're just unable to landmark, that's the big thing, is what you can do is actually come down to this distal tibia, and oftentimes you'll see they don't have as much adipose tissue there, and that will be a site that you can potentially go after. Now, you'll notice I'm standing on this side of my patient, and I'm going after the left leg. This is the best way to do it, okay? Because I want to be with my driver this way as opposed to pointing it toward myself, okay? So landmarking for your distal tibia, what I do it the same pretty much for adults and kids. You put your ring finger on the medial malleolus, which is actually the end of your tibia. And then I take these 2 fingers and I actually walk down both sides of the tibia. And on most people, you can actually feel it all the way down, all right? So then, once you get around to here, it's where this index finger lands, and that's where you would put it in an adult. So for pediatrics, pretty much if you can find the tibial tuberosity, then just go like 1 centimeter medial to it. If you can't find it, try to find their patella. Then you would go kind of 1 centimeter below it and then just 1 medial, right? For the distal tibia, it's very much like I did with the adult. Put your ring finger on your medial malleolus, which is part of your tibia, then take these 2 fingers, and you can actually easily walk them down on most children. Just bring it right down, and it'll be right where your middle finger rests, okay? So that's where you would put it. If you're going after the femur site in a child, which is a site that we don't have for adults yet, it's generally 1 centimeter above the patella, and then it's 1 to 2 medial. So we'll be just sitting just like that. The thing is, when you're doing a femoral site, you have to splint that leg straight, because otherwise, if they bend their knee, the quadricep will pull it out. Another little trick maybe for if you have a little child here who's got one in the tibia, I always loosely tie their ankles together with a triangular. And the reason I do that is because I had a little duffer who was dehydrated, low sugar, so I gave him some fluid, gave him some sugar. And the first thing he did was he perked up, which was wonderful, but then he took his good leg and he kicked out my IO because he didn't like it there, it hurt. And I was very sad when that happened. So anyway, I just loosely tie these together, and it'll allow the kid to flex his legs all he likes, but he can't pull out your line. So now I'm going to have my lovely assistant come, and I think the proximal humerus is one site that most people are a little leery about. I conduct a lot of cadaver labs, so I've done this probably, I would have to say, at least 100 times. And once you do your first one, you'll wonder why you were ever kind of hesitant to use it. So what we're going to do now is just a landmarking on the humeral site. So the most important thing is you have a bicep tendon that comes down into this part of the arm. And so in order to rotate the head around and hide that bicep, you've got two ways of doing it. One, you can put their hand across their chest, or if there's an arrest going on, something like that, just rotate their arm around until it pulls that forward, and again, it protects your bicep tendon. All right, so in this case, we're just going to do this. All right. So there's two ways of doing this, and I think once you do your first one, you'll kind of come up with the way that works for you. The way we teach is using both your hands. One goes into the axilla, and you always have your fingers just to the top of the shoulder. The other one, so you're forming a 90-degree angle here, okay? Then you bring your thumbs together, and then you push in, and you slide up and down. And what I'm feeling for is her surgical neck. So her surgical neck is right there. And it feels almost like a golf ball on a tee. As you're coming up against something like this. And so then I'm going, okay, so I know where the surgical neck is. That's the narrowest part of the humerus. And then we're going to go about 1 thumb above it. So I would go right there. And again, it's not straight out. It's at a 45-degree angle, and you're using the 45-millimeter needle for adult humerus because you don't think there's a lot of tissue here, but actually when we do cut downs in cadaver labs, there's actually quite a bit of tissue in there. And then we're going to be aiming, usually I kind of aim for the opposite elbow. Some people aim for the opposite hip, but generally it's going to look just like this. If you're going to err one way or the other, again, same with the tibia, go high, because you certainly don't want this needle going through that surgical neck, which is the narrowest part. So, and it's a big target up here, but it will sit just like that. All right. Now, the thing about the humerus site, it's got many benefits. It's not a weight-bearing bone. It's not as dense. Also, you can give up to 5 liters of fluid through this site. It's also not as painful because it's not as dense. Okay. Whereas the tibial site, weight-bearing bone, very dense. You're lucky if you can get about 1 liter of fluid through there in an hour. So humeral site is definitely the site you should probably go in after, especially when you've got a time-critical patient. The way I like to do it in a cardiac arrest, I like to come up and just stand at this shoulder. Then once I've got it in and attached to my IV lines, this is where I'm giving the drugs. So you kind of have to own your space when you're at an arrest situation. This is definitely a nursing skill. So own it. And it's not that difficult. It really isn't. Once you do your first one, you'll never be worried about it. So thank you very much. So you have to go over the times when you would not do an IO. And the easy way of thinking about it is if your bone is fractured. Now, if I have a radius ulna fracture, you can still use your humeral site because it's a separate bone. So if it's fractured, if you've had an IO attempt in the last 48 hours, because it takes about that long for that little hole to seal, if there's infection over the bone site. Also, if you come on and they've got big scars going up the center of their knees or across their shoulders, chances are they probably had those replaced with titanium implant. And as good as these things are, they can't drill through titanium. Right? And the 5th reason why you wouldn't start one is you just can't landmark. Okay? So, I'm going to move into the equipment. So the first thing we're going to talk about is your driver, okay? So it's got a shelf life of 10 years, okay? It's good for 500 of those, okay? So when you're checking your kits, try not to do that every time you check your kits, or your 500 will quickly dissipate. Now, a lot of people don't realize this, but there's a little light on the back of it. See how it turns green? That means I've got lots of battery life left, okay? Now, if you have your driver out and you go to insert and you see it flashing red, that indicates you've got only 10% of your battery life left. 10% of 500 is 50, but generally the way I like to look at it is time to get a new driver. Now, if you are doing your insertion and it's flashing red and then you push down too hard, you will actually stall the motor, okay? And then people are going, oh my God, you know, it won't work and stuff. Easy, easy peasy, all right? These things can all be inserted manually. And the humeral site, like I said, is not as dense as the tibia, and you can easily put that in just like you did the old-fashioned way, just a little rotation and then straight into the bone. So just because your driver has failed on you doesn't mean that you can't insert these. Very easy to do. Now, they have a lithium battery, which is not rechargeable, and you can't replace it, so you have to replace the whole specimen. Now, nice thing about it is the needles are held on with a magnet, okay? Now, they come with their cap here, and what I like to do is I hold 2 fingers on here, and then I loosen the cap and pull it off this way. Otherwise, if you don't kind of hold on to it, you end up with this kind of action. So one little tip there. So your needles, they come in packages, generally like this, and they come in 3 different sizes. So there they are. The yellow is 45 millimeters, and the blue is 25. The pink is 15. The way to think about this is how much tissue you are passing through. It doesn't have to do with the age of the patient or anything like that. So just think, these needles indicate how much tissue you have to pass through. Now, I've got some blocks here, which are a really good indicator. Okay, so this is, you'll notice the first line on here is at 5 millimeters, and then the other lines are all 10 millimeters apart. But the first one on each one is always 5 millimeters. Now, the reason for that is, think about this as the cortex of your bone, and that's about less than 5 millimeters, right? And this is the amount of tissue you're having to go through. So this is 15, and generally I only would use this on kids that are under a month old. And like I said, in some of these cases, I've actually got a little toddler here, and there's no way you'd be using a pink on him. He's just got lots of little rolls there you'd have to get through. So first thing you do is you just push it through the tissue. You don't drive through the tissue. And you can see I've popped down, and now I'm touching the bone, okay? And then I'm looking, and I've got 1 line showing. You've got to have at least that first line showing. Sometimes, say you've opened up your kit, and someone didn't restock the aircraft, and all we have are these. And you can see when I'm touching the bone here, I've got like 2 lines showing. But that's okay, you can still use it, but you know that you're not going to insert this all the way to the hub. You know that your needle's a bit too long, but you only insert it till you feel a give, and there you are into the honeycomb, into the soft bone where the blood vessels are, okay? This is probably another good example here. So this is 25 millimeters. Again, we pop down through the tissue. We're touching bone. I've got easily one line showing and almost the second one. And then if I insert it to the hub, you can see I'm just right in the sweet spot there. The next thing we have is the extension tubing. Right? The extension tubing holds 1 cc of fluid. It can either hold 1 cc of lidocaine or it can hold 1 cc of saline. It's got a little clamp on it. Works very well. We also have a wristband that comes in your kit. And I would suggest that if you've done a tibial site, put this on the wrist so it's easily seen by someone, because a lot of times you're not going down to look at their feet. Put the date and time that you inserted it, because they're good for 24 hours. Right? And it's got a 1-800 number on there, and there is someone there 24 hours a day waiting for your call. Usually the questions are always 2 questions. How do I get it out? And can I give this drug? That's usually the 2 questions they're always asking. But you can phone them 24 hours a day. There is someone there waiting for you. And you also have, I call a little mouse trap, but this is where you put your sharps. So inside of each of these needles, there's a stylet, right? And what this does, it prevents the bone from filling up the center of your needle. And it will go into your sharps container. Okay, now this is your securing device. And I know some people don't understand why the center part moves like that. So I'm going to give you a quick example. All right. So what I'm going to do is I'm just going to quickly show you how fast I can insert this. I first push it through, and now I'm touching bone, okay? And I look and I've got, holy cow, I've got 2 lines showing. So I know I'm not going to insert it all the way. Right? Now, the nice part about this is I can actually see how far my needle went in. Patients, unfortunately, you can't do that. We're going to remove the stylet. Somewhere nice and safe. So now we've got our securing device. You'll notice it's sticking up above the tissue, and that's exactly what this telescoping part does. You just set it on there. There you go. And it sticks up just so it can stabilize that needle for you. All right. Now, I actually have this one cut for, I've had some ped nurses say, well, you know, these securing devices, we're not able to, they're too big to put on a kid's leg and stuff like that. But the easy way to do it is just cut them on each one, and then you can just fold them over like that, and that will make a very nice dressing on your little child's leg, and it works extremely well. So we have this in here. We've had our securing device on there, and now we're going to take it out. So the way you do this is you take like a 10 cc syringe, right? Pop it on, put it on clockwise. If you do it counterclockwise, it just unscrews itself, so it's pretty easy. Now, I like to have the other hand kind of further away, because I've heard of cases where you actually pull this out and then you reflex and you poke your hand. So I like to give it kind of one twist, and then you'll see my fingers are right down near the needle, okay? And I'm twisting it and kind of pulling at the same time. And that way I've got full control over that needle. I don't want to see someone trying to pull it out up on the top of your syringe. All right. Good indication of how dense a tibia can be. In Edmonton, they had a weightlifter who came in, and he had one in his tibia. And they went to take it out, and they actually snapped the plastic right off the hub. And they're going, oh my God, it must be bent in his leg. And they x-rayed it, it wasn't bent. And so they ended up getting a pair of pliers, and they just pulled straight out, and it came right out. But that's an indication of how dense his bones were. So. Now your lidocaine, so if you have someone who is arresting, peri-arrest, or where it's time critical, we don't have, I always ask myself, do we have 3 minutes? Normally it takes 5 minutes to do the full lidocaine treatment, but in some cases you can break it into 3 and then do the 2 minutes later. So I always ask myself, do we have 3 minutes for this patient? Now, you may have someone who needs an airway right away, but the SATs are low and you need to do 2-person bagging and you're trying to pre-treat with some oxygen and stuff. So you probably will have a few minutes, at least 3. And in those cases, your patient is probably, could have a GCS of 10, who knows, 10 or 11. And if you're able to do this, give that 3 minutes, get some lidocaine into that bone, that patient will thank you forever. So, say we have a patient who's in cardiac arrest. Very simple here. All you do, see, I'm pretending this would be the humeral site. Okay. Cleaned off my site, pop it through. I've got at least one line showing. Okay. Take this off, putting my extension tubing on there. And then I'm going to, this will already have been flushed with saline. Pop it on here. And then I would take the clamp off. You don't have to aspirate. You can if you want, but you don't have to. Sometimes you can aspirate and you won't get any bone marrow. Sometimes you will. When I've done this in patients that have a beating heart, I've actually had blood start to drip out of the humeral site. And in that case, you can actually do a really quick glucose. If with an ISTAT, there's, I think the big ones are you get a hemoglobin that's correct, you get a glucose correct, hematocrit, BUN, chloride, things like that. But the other electrolytes are generally inaccurate. But you certainly can get your glucose and your hemoglobin off of here. So once you've got that flushed, pop this on here, open it up, and I flush it. And I generally, for adults, it's usually 5 to 10 cc's. For kids, it's 3 to 5. But the old saying is no flush, no flow. So if I can't flush it, then we're not in the right hole. And you'll notice I also hadn't secured these yet. And that's the reason why. If I'm doing this and I can't flush it, then obviously it's just not in the correct spot. And I've already got it secured to the part. So that's why I always wait to see if it's in the right spot. Then I pull my tabs, and then I secure it that way. Now, if you have a patient who requires the lidocaine, it comes in 2 different ways. This is probably the way most people are familiar with. It's 2% lido, stuff that we still use for cardiac sometimes. It's 20 milligrams per cc. There's 5 cc's in here. And it also comes in this container as well. And apparently this is the most financially best way to do it anyway. It's a lot less expensive than this. So the thing is, lidocaine is clear. Okay, when we usually do training, I always put some food coloring in here so you can see it. This is where you have to really, I always say, stay frosty. If you're the one doing the lidocaine on your patient, make sure that you're not being interrupted with other things. When we were doing one cadaver lab, we had someone inadvertently sucked up the whole thing and then thought it was the flush and gave it as a flush. Lidocaine, when it's given quickly like that, is going to go centrally, and if your patient is the least amount awake, will have trouble talking because their tongue is numb, their lips are numb, and it's not good for the heart, especially if they've got any conduction problems. So that's why you only want to numb the bone. You don't want it to go centrally. Okay? Now the other safety feature I like to do is you open this up, and then I only draw 2 cc's at first. Okay, and I leave 3 in here. And then I make sure I got a label on there that this is lidocaine, all right? So if this patient is conscious and stuff, what I do is I put this on here, all right? And I'm gonna inject 1 cc into the tubing. So I've got 1 cc of lidocaine in your tubing and 1 cc in your syringe, okay? Now, in this patient, I haven't done the flush yet. Okay, you do not do your big flush prior to doing the lidocaine, okay? So you put this on, and then I usually just go by my own watch. Over the next minute, I'm slowly gonna give that lidocaine. And when I mean slowly, I don't mean for you to do like kind of a 10th at a time, 10th at a time, or something like that, because that's all it takes is to get out into the central. You just wanna slowly give the whole thing, all right? So that is given slowly over 1 minute. So now you've got 20 milligrams in your patient, you got 20 milligrams in your tubing, and your syringe is empty. So now, this is where you can take your saline on here, and you're gonna give 1 cc of the saline, because all that's gonna do is slowly flush that out. So you're gonna give this over a minute. All right? And then, since you're able to put the medication in there, you can pull your tabs and secure your device. But just let it sit there for a minute. And this is the most critical part because you want that lidocaine to just really soak through all those blood vessels into that soft part of the epiphysis, and you just want to numb that bone. And I always say it's kind of like marinating the bone marrow. All right, just let it sit there. And then, after your minute is up, then this is where you're going to give your flush. Okay? And depending on what's wrong with your patient, if you've got your SATs up on your critical patient, you can now go ahead and do your RSI medications. You can go ahead and give your TXA or whatever it is, your 3% sodium, whatever it is that you need now, you can actually give. And then you can actually, once you've kind of got those medications on board, you can go back. So you've still got 3 cc's of lidocaine in here. So then what I would do is draw back 1, all right? Disconnect this. Now, this has saline in it, right? And this is my lidocaine. So you can attach this and just do it quick because you're not actually giving the lido. You're just moving it from the syringe to the tubing. And again, you put your saline on here. And again, you just do it very slowly over a minute. Then you let it sit for a minute, and then you can flush it. So the whole thing with lidocaine takes 5 minutes, but you can break it into 2 different ones. If you've got 3 minutes to spend on a patient before you have to do something critical, you certainly have time to do the lidocaine. And I think it is probably underutilized in those situations. I think there's still that thing, I'm going to hurt the patient, or, I'll rather give my meds IM or something. And if you've ever had an IM medication, I'm sure you'll realize they're not exactly painless either. So that's kind of the whole thing. I'm just kind of wrapping it up with some tips and things like that. Always use the right size of needle, okay? Get the right location that you're going after, okay? You have to use a lidocaine if you need it. You have to do the right amount of flush. And then these things generally will not run just on gravity. You need a pressure infuser, or you can hook it up to a pump. Now this is set up for pediatrics, but it could also be used for an adult. In this case, you've already got your extension, you've got a Y connector on there. You can actually take this, hook this right onto your Y, right? And this way, if it's a child, you can, depending on what your bolus is, 20 cc's per kilo, you can actually suck it from the bag and turn this off and do it that way. Or sometimes what works better is if you've got a stopcock going in there, but that works extremely well. I had a trauma patient just a few months ago, was peri-arrest. One patient was already having CPR in the ditch, and in that case, one look at her, they'd already tried multiple times, both her legs were broken, and I just went up, we did the humeral site. It was so quick, I'd say we probably had it inserted in under 20 seconds. And we gave her RSI drugs and got her intubated. And then while we were getting our stretcher ready, I had the paramedic do the TXA. So he was doing that while we got her moved across, got her in the helicopter, we're moving toward Calgary. And in that space of 20 minutes, we not only had her intubated and had TXA on board, but we also gave her 2 units of Paxils. And the way I gave it was using this kind of a poor man's level 1 infuser, and it worked extremely well, and that patient did survive. So that's just kind of a good example of like, you have to remember that these needles are big. They're 15 gauge. They're bigger than anything that most people insert on a scene, and they're stainless steel. Now, because of that, because of the fact they are metal, they can't go into an MRI, or it will remove them for you, okay? Now, you can use them in CTs. So if they're going for a CT, that is fine. Now, often when they go for a CT, they'll want to do high pressure contrast. Now the tubing here is not rated for that amount of pressure, but what you do is you just disconnect it from the hub, and then you can put the diagnostic imaging port right onto there, and that will work fine. Now if you have a CT where they're wanting to do the chest and they always want to put the arms above their head, that probably won't work if you've done a humeral site, because when you move the arm up, it will probably pop it out. So in that case, it's probably better to get your patient to the hospital with the IO, and then hopefully they can get another line in there, and then they can go for their CT. There's only 4 times you would ever actually hook a syringe right onto the hub. One is when you're taking it out. That's an easy one. One is when you're at CT, okay? One is with, say you're in a hospital. Like I said, you can actually do glucose right off of that, but you can also do blood cultures right off of that. But the thing is, don't flash it, don't put anything in there, and have your lab there, and they can actually withdraw blood and send that to the lab. Because cultures only have to grow in Petri dishes, whereas you don't want your lab drawing blood from here and sending it to their machines, because there is tiny little microscopic fragments of bone that can upset their equipment. So that's why an iStat works well, because it doesn't utilize that principle. But say you also have a little kid. Now the dose for adults is generally 40 milligrams of Lido, the initial dose, and then your second dose is half of that, so 20 milligrams, right? Now for a kid, it's 0.5 milligrams per kilo. So if you have a little duffer who's 10 kilos or something, you're going to end up with an amount of lidocaine that's less than 1 cc, okay? So this holds 1 cc. So if you only put half a cc in there, then you're going to have to probably fill the rest with saline, which will dilute your Lido, which is not what you want. So in that case, I would draw up your lidocaine. I'd probably use a 1 cc instead, and then you actually put that directly onto the hub, and then you're slowly giving that amount over 2 minutes. because you just don't want to lose that lidocaine in the tubing. So those are kind of the 4 times you would ever put something directly onto that. The big thing is no flush, no flow. If you can't do that, your site is in the wrong spot. Humeral site, like I said, is our preferred site at STARS. It's, you know, if you've got a cardiac arrest going on, that is where you want to be. And I always say, just own your space. This is a nursing procedure. It's an IV procedure just like you would do on any other patient. And the other thing is, I've always had helpful people at codes, and I've had one where they were actually moving my IV pool around and pulled the line right out. And it was very sad. So what I do is when I have a line into my patient, whether it's IO or whether it's just a peripherally started one, I always have a hold of the tubing, like right here, and then I've had it where they actually pulled my pool right over, but I didn't lose my line, all right? And I also do that when I'm transporting them down the hallway. So if I pull my pumps over, I pull them over, but I don't lose my central line or whatever this is attached to. The humeral site is the preferred site at STARS for several reasons. First off, it's not a weight-bearing bone, so it's not as dense. And because of that, any infusion or medication going through there will tend to be not as painful. Now, the site for it, this is a very good, I think, illustration of it. Again, like I was saying, it's going to be at a 45-degree angle, and I tend to aim so you're actually aiming off to the opposite elbow. The other benefit of the humerus is because any medication put through there will be into the heart, and here's within 3 seconds. So there's actually a really good YouTube video on that, but anything inserted into the proximal humerus will be into the heart within 3 seconds. The other benefit of the humeral site is you can give up to 5 liters of fluid per hour through that site. Now the tibial site, it's also a good site, but it's got a few drawbacks. First off, it is a weight-bearing bone, which means it's very dense. And because of that, any infusion going through there will tend to be more uncomfortable. And you can also generally only give about 1 liter of fluid per hour through the tibial site. The most critical factor I want to reinforce with everyone here is the importance of the flush. What the flush does is it opens up a little channel and it pushes the fibrin and marrow aside in the epiphysis. So it's making a little channel for your infusion or your medications to go. So that's why it's critical. Like for adults, you give 5 to 10 cc's of flush, and for kids, it's 3 to 5 cc's. And depending on the site, generally for the tibial site, you may have to repeat your flush after 20 minutes or a half hour if you notice that your infusion is starting to slow down. And it's not a big deal. You just go and repeat your flush, and then it just opens up that channel and allows your infusion an easier pathway into the central circulation. So I think that's pretty much all I wanted to cover today. Hopefully this video covered, I gave a good overview of intraosseous and how it works. And I hope it was a good refresher for those of us who have actually done quite a few of them. And I'd like to thank you for watching.